We all have been using GnRH analogs for quite some time. And we have been initially it was available as a daily injection, then it was available as a weekly one, then it became 4 weekly. Now we are using 12 weekly. There is one which is a yearly injection which is available. Now Dr. Vibha is going to shed light about this new long acting GnRH analog which is going to work about in terms of 45 milligrams. Then we have a follow-up paper also on a similar ground which Dr. Sandeep will talk about.
Thank you, sir. So I'll be discussing about this newer long leuproid acetate that they have used 45 milligrams 6 monthly subcutaneous. Its treatment and its treatment use in monitoring. So the paper has been discussed, the why study is being done and how they have done the study and what were the results and what this study will have the impact on the clinical practice. So we all know that during the treatment of the precocious puberty, we all need to monitor the patient. We do it clinically, and when there is a discordance between the laboratory values and the clinical parameters, we often go for the GnRH stimulation test. And the study says that this GnRH stimulation test should be done in each and every patient during this treatment part because it helps in to verify the adequacy of suppression of gonadotropin secretion. So we generally use leuprolide acetate subcutaneously with a dose of 20 microgram per kg, and the another one is tiprolin with a dose of 100 microgram subcutaneously. So the study has used leuprolide acetate of 45 milligrams 6 monthly, and it was given subcutaneously. The main question, they have postulated that the therapeutic subcutaneous leuprolide may also be used to monitor the response in the central precocious puberty in place of a traditional GnRH stimulation test. So they conducted a study on the basis of this hypothesis. And the main question, why they have used this therapeutic treatment as a for the monitoring, not the traditional GnRH stimulation test, because GnRH stimulation tests are not practical, they are often expensive, and the child have to give an additional injection for the monitoring, which give a negative impact on the clinical experience of the child, and the parents have to give extra time for this stimulation test, and it bothers the families and the children as well. So that's why they found that the giving using this treatment part for monitoring will be good for both the families and the children. And the study was conducted on the basis of this non-published data of this small study, where they have used a small volume of subcutaneous leuprolide acetate for the treatment of central precocious puberty, and the data was used from this study. It was a phase 3 multi-center study, open label, and a single arm study. There was no control arm. It was conducted between August 2015 to September 2018, and 25 sites in 6 countries were involved in the study, and they have given subcutaneous leuprolide of the dose of 45 milligram at the interval of 2 weeks. They have given 2 doses and have seen the response. The study population included 60 children with the girls of age between 2 to 8 years and boys 2 to 9 years. They were the confirmed cases of central precocious puberty, and the diagnosis criteria, the confirmation of precocious puberty was based on the clinical evidence of puberty, which was defined as if the pubertal stage of breast stage more than or equal to 2 was present in girls and testicular volume of more than 4 ml, and if the bone age was advanced by at least 1 year with as compared with the chronological age, and if the pubertal LH response was more than 5 international unit at 30 minutes subsequent to GnRH analog. And they excluded all the peripheral precocious puberty cases, non-progressing, isolated premature telaki, previous seizure, or any chronic illness. And for the confirmation of the diagnosis, they have used the leuprolide acetate via subcutaneous method with a dose of 20 microgram per kg. Now, during the study, what they have done, first they have made the clinical diagnosis, And they have screened and monitored the patient during the treatment at 12, 24, 36, and 48 weeks. And they also collected some samples for random LH and FSH and estradiol at 4, 20, and 44 weeks to evaluate the pharmacokinetics, as it is a newer drug. This 45 milligram is quite a huge amount, and to check its pharmacokinetics, they have collected the samples at 1, 6, and 1, 3, 1, 4, and 6 hour. And they have set the cutoff for adequate suppression to pre-pivotal levels, that was LH less than 4. And in the results, they have found that after giving this opioid acetate of 45 milligrams subcutaneously, the LH level, there was an initial surge in the first 4 hours. As we can see that it was a surge of around 40 international unit. Then it very well correlates with the serum concentration of the leupride. Then it becomes stable. And if we see that they compare the genetic stimulation test and this 45 milligram 6-monthly dose, what they have found that there was a suppression in both the cases which was less than 4, and this 45 milligram was given at a 24 week interval. And if we can see the black line, it was between the 1 or 2, I would say. The LH level was below 1. And if we see the GnRH stimulation, post GnRH stimulation, the level was below 4. It was around 3 international unit per liter. So on the basis of this, we can see that it is this 45 milligram leuproid acetate with the dose of 45 milligram given at an interval of 24 weeks is equally sufficient in suppressing the LH levels, as well as it has a rise after within the 4 hours. They have also compared this leuproid acetate with the traditional GnRH stimulation. As we can see in the first two studies, where the 7.5 milligram monthly dose IM and 3.75 milligram monthly dose IM was compared with the traditional one, and they have seen that the peak rise was equivalent to the traditional GnRH stimulation test, and the suppression was also less than 1 in both traditional and this 7.5 and 3.75 milligram leuprolide acetate. And if you see on the last column, where they have used the 45 milligrams leuprolide acetate given 6 monthly, it has shown the similar result with a rise in the LH levels more than 40, higher than the traditional GnRH stimulation. But it has this study incomplete because they have further studied it further and given the results of suppression. I would show in the further slides. They have compared the subcutaneous leuprolide acetate with the intramuscular leuprolide acetate, and they have found that both have showed the initial burst within the first 6 hours, as was shown in the graph, and the concentration decreased and remained stable for a while. The girls achieved pubertal levels of estrogen less than 20 after the second dose, that is after the 42 weeks. And the boys achieved the pubertal levels at 36 weeks. So if I conclude the study, it has shown that as compared to the intramuscular leuprolide acetate, subcutaneous also yields a similar burst release of leuprolide and induces a similar rapid rise in the stimulated LH levels in response to the first dose. And it also has an adequate suppression of the sex steroids subsequently. If the therapeutic dose of 45 milligram, if it is given at 6 monthly interval, it will be easy to monitor the treatment efficacy, and it will provide more flexibility and the utility, and it will be more cost effective and easier than traditional GnRH testing for the patient and the family.
Subcutaneous, there are other studies also about subcutaneous leuprolide use earlier?
Subcutaneous, intramuscular, no sir. This is the first one for the subcutaneous.
Which use subcutaneous as well. The only concern is about subcutaneous, the volume may be a bit more.
Yes.
So that is the only concern which
they have used the data.
But many people, even with the current preparation, use subcutaneously.
Yes.
Because they say steroid abscess is another thing that
Less likely to be.
The concern basically is that one, it is a depot preparation.
Yes, sir.
So depot preparation, if you give it the muscle, it may store there for a longer time.
And
So did they mention any previous study of subcutaneous?
No, sir.
They didn't mention.
No. They have only compared the intramuscular with the subcutaneous one.
What is the volume there?
0.675, very small volume. 0.375 ml they have used. Yes, sir.
That makes sense. But if you're giving 2 ml or something like that, as a
Yes, sir.
it may be more difficult, painful, local
Yes, sir.
swelling, other things will be there. So I think one big thing is that if you're giving subcutaneous, it will become much easier in
and
terms of pain. And the second thing,
frequency.
did they mention about the 4 weekly or 12 weekly? Because a lot of people use that as stimulation test. Like we do not do a GnRH test, we just look at after 2 hours or 4 hours of that. So did they mention about that in those ones?
Sir, they have mentioned this tradition that was a Guzrelin.
No. What I'm saying is that
No, 12 weeks and
lot of people do this.
No. They have not mentioned about this 12 weekly and 6 weekly Lupron that we go for. No, they haven't mentioned.
So because routinely most people don't do a GnRH.
Yes, sir.
They will just use that as idea. What is the basis of using this injection of GnRH as a stimulating agent? So what is the rationale of their stimulation there? It's a long acting, so why will it stimulate?
Initially, because the initial burst
Why? That initial burst is different. That is because of the flare response. What they're trying to say is that when you have a GnRH analog, some amount will be free. It will be rapidly rising. And that free part is what you're effectively is behaving like a GnRH. So that's what they're saying.
Yes.
But then the issue would be whether it's really the same amount of that, whether the amount will be same for every injection. Some may have more free, some may have less free.
Yes,
but I think this is a good idea,
This
which
could be
reverberates our idea that we can use it as a suppression strategy.
Yes, definitely. This study has a good impact will have a good impact in the clinical practices because the less monitoring is required as it is given 24 weekly intervals. So it also reduces the additional injections. It has a very minor adverse effect like injection pain, rash, nausea, vomiting, which is minimal. And the similar therapeutic dose could be used for the monitoring as well as for the treatment. So it has a very good impact on the clinical practice. Yes, generalizability, it could be applied in the general population because it has no such side effects or variations. It is advisable for the children with central precocious puberty, and the intervention is very feasible because this 2 injection has to be given for looking the suppression of the gonadotropins. The limitation of not this study, but the data from which the results is derived, they have used the peak LH after 30 minutes only. So for the treatment purpose, I would say this is the limited.
Have a more rapid onset of action, subcutaneous or intramuscular?
This intramuscular, this is deeper. So
which will have faster. So if you want to look at
subcutaneous is faster.
If you want to look at LH after an IM,
yes, it will take time.
2 to 4 hours. But if you are looking at subcutaneous, it will be more rapid. Like we say, if the lantus you are giving, if the short acting you are giving in that intramuscular, you may have a different onset of action. Same.
And similar, there is no long-term follow-up. They have just used 2 doses. And later on, they have not followed up. And there was also very low boys to girls ratio. So that's it. Thank you.
I think that's a very good presentation. Dr. Bajpai has highlighted about main thing I think here is that we have a new preparation. Now it's not available here at the moment. Is it available routinely there? There also it's not available. No. You have checked it. Is it available? Because the study you mentioned was much longer, earlier study. That preparation, Hysterlin was once in a year, but that you have to implant. You have to make a cut and then put the thing inside. So that is a bit of a painful thing. And then the suture is to be given. If you give an injection 6 months, which is good enough. And if it's a very small, then it's something like denosumab. It's like a subcutaneous injection. So it becomes much easier. So I think the key messages which Dr. Bajpai has clearly highlighted is that we have a new preparation which can be used once in 6 months. You don't need to worry about GnRH stimulation, and that is not required. You can just look at the LH levels after 30 minutes and you will get the idea. Now, the whole idea is when you are monitoring in terms of follow up in terms of precocious puberty is whether you need to really go ahead with biochemistry. Because all the guidelines that are looking at, they are mainly saying that the clinical suppression is most important. And you need to look at the biochemical parameters only after your clinical suppression is inadequate. I see many patients in which the dose frequency is increased just based upon LH level. So what people will do, they will look at LH, LH is 5, they will make it 10 weekly, then they will make it 8 weekly. Don't go by numbers because that can be confusing. However, if you want to go by numbers, these numbers are validated by GnRH stimulation test. And we don't have access to GnRH. So don't use the same numbers every time. So maybe have an idea, but these are not the final deciding factor. And I think these points will be highlighted by Dr. Sandeep, who is going to talk further about these parameters, about how unstimulated. Now, the other issue that why worry about anything, just do an unstimulated level. All of you can go through these articles, they are available, and that will be of help. You can go and have a look at our website, our courses to explore the publications and our mobile applications in that regard. So this has been important issues that we have been discussing about.